Good afternoon, everyone. My name is Chris Palmer, and I am a psychiatrist. I'm the director of the Department of Postgraduate and Continuing Education at McLean Hospital. And on behalf of McLean Hospital and Harvard Medical School, it's my great pleasure to welcome all of you to tonight's webinar. This webinar series is really focused on borderline personality disorder and providing information and support to families and patients affected by borderline personality disorder. Tonight's topic is going to be on symptoms of BPD in adolescents. As some of you may know, you can't officially diagnose borderline personality disorder prior to the age of 18, but we'll hear more about that during tonight's webinar. Before we get started, a few logistical announcements. We really do expect and hope for your participation in the form of questions. We really want to answer any questions that you have. If you're struggling with a specific situation, we welcome the opportunity to help you with that or at least give you some feedback on it. However, in order to maintain everyone's confidentiality, all of your microphones have been muted, and none of the other participants can see your names or email addresses. And instead, you'll use the Q&A box in the lower right-hand corner of your screen to type in your questions. Once we get to the question and answer session, I'll be moderating, and I will read as many of those questions as we can, and we'll have a hopefully informative discussion and get through as much of that as we can. I want to point out that there are several web-based resources in your lower right-hand corner, or lower left-hand corner, I'm sorry. So if you look at the lower left-hand corner of your screen, that first link will take you to our website, which actually includes all of the archived webinars that we've done prior to tonight. So if this is your first time logging on, you can actually go there and view any of our prior webinars. This webinar will be recorded as well and will be posted to that site probably within the next week. Additional resources, especially if you're looking for a treater or a consultant in your area, the next two resources we strongly recommend because they can provide national resources for treaters throughout the country who have specialty in borderline personality disorder. And finally, I want to, well, not finally, so next to finally, I want to announce that the next webinar will be June 22nd. We will be hearing from Dr. Amy Gallardi on comorbid diagnoses with borderline personality disorder. So as many of you know, borderline personality disorder is often associated with other conditions like depression, anxiety, eating disorders, substance use disorders, and so on. And she'll be speaking on that topic. If you'd like to register for that webinar, the link for that registration is right there in that lower left-hand box. And then finally, I want to recognize a special family who wish to remain anonymous, but who gave a significant gift to make these webinars possible so that we can bring you all of this information for free. However, we are asking people, if you're in a position to be able to help support these webinars, we would love to be able to continue these indefinitely. And any gift, large or small, would really help us to do that. And so there is a link in the lower left-hand corner titled Support These Webinars. If you do want to support these webinars, I'd ask you to go to that link. And when it asks you what you want to give to, please do not select the McLean Fund, because that will go to the general McLean Hospital Fund, which gets evenly distributed throughout the hospital, and instead select Other, and then specify BPD webinars. And then your gift will come really solely for these webinars to help support future webinars. And with that, it is my pleasure to introduce tonight's speaker. Tonight's speaker is Dr. Judith Mintz. She's Director of Clinical Services at our 3 East Intensive Program and Intensive Step-Down Program, which is a program that specializes in the treatment of adolescent girls who have symptoms of borderline personality disorder. So that really makes her expert in tonight's webinar topic. She's also an instructor in psychology in the Department of Psychiatry at Harvard Medical School, And it is my pleasure now to turn the webinar over to Dr. Mintz.
Good evening, everybody. I'm so glad to be here and to have the opportunity to talk with all of you about borderline personality disorder in adolescents. Okay. This is a really special opportunity because I think this has been a very neglected topic and in many ways a taboo topic. So I'm hoping to dispel some of the assumptions and some of the prejudices about this disorder in adolescents. So I'll just briefly go over some of my objectives in what I plan to talk about this evening. The first is I'm going to start with talking about the history of diagnosing borderline personality disorder in adolescents. And then I'm going to talk a bit about how we understand what borderline personality is. And then I'll move on to talking about the most common symptoms and some of the criteria for diagnosing this condition. As I go along, I may mention other diagnoses that tend to either co-occur or have been given in the place of borderline personality disorder with kids. We see that quite a bit since, as Chris mentioned, historically we don't give this diagnosis till individuals are at least 18, so they often receive other diagnoses. Okay, so let's first start with the history. Instead of people seeing many of the symptoms that we now look at as indicative or red flags of borderline personality disorder, many people have often thought that adolescence is a period of storm and stress. It's just turbulent and rocky, and all adolescents experience a lot of difficulties in moods. So that's been one reason that people have tended to normalize, clinicians have tended to normalize, and parents sometimes have tended to normalize the symptoms that are emerging and can indicate borderline personality disorder in adolescents. On the other end of the spectrum, when clinicians have met with or evaluated adolescents who have emerging borderline personality disorder traits, they have tended to interpret those signs and symptoms and signals as symptoms of other disorders. And some of the most common ones are depression, bipolar disorder. At other times, the behaviors that are typical of the disorder receive the diagnosis themselves. So eating disorders like anorexia and bulimia, substance abuse, and even PTSD are very commonly given to adolescents. Now, by the way, this doesn't mean that adolescents don't have those disorders as well. Any of those disorders can and often do co-occur with borderline personality disorder. But we'll talk a little bit about why it's a problem when the borderline diagnosis can't be made as well. And I think the final reason that historically people have shied away from making this diagnosis in adolescence is because there is a tremendous stigma attached to this disorder. And that, of course, is not true only for adolescents, but it has been true throughout history for adults as well. I think that stigma, which hopefully we are working very hard to undo and correct, has been a factor in people being even more reluctant to give this diagnosis when they do see the symptoms in adolescence, because there's been a fear that the disorder is untreatable, and that essentially people are being told their child has a hopeless and condition for which there is no help. The good news is we know now that's not true. So let me just address some of the common myths and assumptions that go along with the idea that adolescence is just normally a stormy, stressful time. The first involves the idea that borderline personality disorder involves intense and unstable moods, and that is a very core aspect of borderline personality disorder. And many people will say, but aren't all teenagers moody? Isn't angst a normal part of adolescence? Isn't this just what it is to be a teenager? So that's one. The second is that we'll see a number of symptoms cluster around impulsive or risky behaviors. And again, people will often come back with the thoughts that all adolescents tend to experiment, or many adolescents tend to experiment with drugs. They're finding their sexuality, so it's not uncommon for them to start having sexual experiences. And of course, eating disorders are very, very common. So that becomes another assumption that would lead people away from seeing these as symptoms or signs of borderline personality disorder. And finally, Another set of symptoms in borderline personality disorder cluster around unstable relationships and an unstable sense of self and difficulty maintaining a stable identity. Adolescence, of course, is a time in which peer relations, new relationships, and identity are all part of the developmental process. Okay. So why is the failure to diagnose borderline personality disorder a problem? Well, without accurate diagnosis, adolescents often receive either no treatment because, again, there's a tendency to minimize the symptoms or assume they're just part of normal development, or they receive ineffective treatments. So for instance, if an adolescent is given a diagnosis of depression, and actually they are suffering more accurately from borderline personality disorder, they may receive CBT, which is a very effective treatment for depression, but as Marsha Linehan discovered many years ago when she developed DBT, which is treatment for borderline personality disorder, it doesn't actually work for borderline personality disorder. So that CBT that is so effective for depression, not so good for borderline. And another common treatment that adolescents receive, they are often put on many, many medications, mood stabilizers, antidepressants, medications to treat anxiety. Now again, I'm not saying that they don't necessarily benefit from some of these medications, but if the primary symptom picture is more fitting of a borderline diagnosis, often we will hear that these medications are not very effective and they're not in fact treating the symptoms that the kids are reporting. So what is borderline personality disorder? Well, we see it as a core problem with regulating and stabilizing emotions and behavior. We also now do see this as a condition that does in fact emerge, or traits become very apparent during adolescence. And the pattern of symptoms typically involves the experience of very frequent negative and reactive emotional states, interpersonal struggles, an unstable sense of self, and unstable identity. And finally, we see a lot of risky and impulsive and reactive behavior patterns. Now, before I go on to talk about some of the specific symptoms in more detail, I want to also talk about the fact that we have learned that many individuals with borderline personality disorder have what we call temperament traits or temperament factors in common. And these temperament traits all involve what we would call emotional sensitivity. So what are the components of emotional sensitivity? The first is a tendency to experience a very, very high degree of emotional intensity. And that means emotions, when they show up, come on very strong. Individuals, adolescents will often say they go from 0 to 60 in a nanosecond. Now, along with that, they also tend to report experiencing emotional and behavioral reactivity. And that means these emotions come on very quickly and very suddenly in reaction often to any kind of event in the immediate environment. And not only do the emotions come on very quickly, but the pressure to move into some kind of behavioral action or reaction is also very swift. And finally, these individuals experience what we call a slow return to baseline. Well, what does that mean? That means even though the emotions show up very quickly and they are very fast and they're very intense, they take a very long time to subside. And it takes quite a while. Adolescents can go through a very long period, hours, if not days, before they feel stable and okay again. Now, one word of caution, not all people who have these temperamental traits have BPD. So how do we distinguish normal from pathological in adolescence when it's quite common to see some of what I've just described? Well, there are a few variables or dimensions that help us try to make this differentiation. The first is that the symptoms are persistent and pervasive. And that means they're not limited to a particular time or situation. We should see them over a period of time and in a number of contexts. So for instance, to even consider whether an adolescent is having emergent borderline personality disorder symptoms, we really need to see and hear a history of symptoms that have been present for at least a year. We also need to know that these symptoms are happening maybe at home and at school, in their peer groups. Maybe they're getting into arguments with teachers, but they shouldn't be limited to one specific situation. And as the adolescent progresses, the behavior problems tend to become more extreme. I think one of the most important dimensions, and this is going to be something I reiterate again and again, is that the behaviors that we typically see in borderline personality disorder and when we see this emerging in adolescence are typically prompted by poor emotional tolerance. So that means when those fast, intense emotions show up and they stick around, many of the behavior patterns we see are prompted by a desperate need to change the emotional state. Okay, so I'm going to start going through some of the symptoms, and the way I have organized my thinking about this is I've taken the DSM criteria and I've put them in certain categories that generally will organize the different symptoms. So the first is negative affect and emotion dysregulation. And if you look at the top of the slide, I have the 3 of the criteria for diagnosing borderline personality disorder: intense depressed mood and irritability and anxiety that lasts a few days or hours, intense and uncontrollable anger, and feelings of boredom and emptiness. So if you think back to what I said about the temperament dimensions, these mood states are reactive and they tend to be triggered or prompted by moments that just occur. So you can have an adolescent who wakes up and on their way to school, they're seemingly feeling fine, and then they have an argument with a friend, and their friend says, you know, you really haven't been treating me very well. And very rapidly, that adolescent is likely to feel very intense emotions, and whereas any adolescent might be upset, the adolescent with emerging borderline personality disorder, those mood states are just going to increase and increase and increase, and they are going to feel an increasing sense of desperation. Now, to make matters more difficult, it's very hard for individuals with emerging borderline personality disorder to validate or make sense of their feelings. So they're very prone to judging their emotional reactions, even as they're suffering very much from what they are experiencing. At other times, they might not be able to feel connected to their feelings at all. They often will say, I'm overwhelmed, but they can't identify any specific emotion. Okay? So these very intense emotional states that stick around and lead to a lot of suffering tend to prompt very impulsive and dangerous behaviors. So some of the most common behaviors that we see in adolescence are risky, casual sexual encounters, drug use and abuse, eating disorder behaviors like binging, purging, and restricting. Now, in some cases, those behaviors may meet criteria for a disorder all on their own, but what makes them particularly notable as possible symptoms of borderline personality disorder in adolescence? Well, again, it's the pattern in which that sudden surge of emotion and the inability to identify it or to validate it or to comfort oneself or to find ways to cope with it effectively lead to a need to move into a behavior that will change the emotional state. So the function of the behavior, whether it's drug use, whether it's casual sex, whether it's some kind of eating behavior, is to change the emotional state. So the symptoms, any of these symptoms can come and go, which may or may not differentiate them from a primary substance use disorder or an eating disorder. Now, the most concerning behaviors that we see, the most dangerous behaviors that we see in adolescence are suicidal behaviors and self-harm. Suicidal behavior and suicidal ideation can, of course, occur and does frequently occur in many other psychiatric conditions. What we see in adolescence is many times these suicidal thoughts are, again, in reaction to a sudden event, or their suicidal behaviors are also reactive. So many times they don't report having made a plan for suicide or having planned a suicide attempt. In fact, many suicide attempts are reported, particularly if they're done by an overdose, Many kids will tell us that they couldn't think at all. Something happened, their boyfriend broke up with them, or they got some really upsetting news, or they felt insulted by somebody, and they went upstairs and they just took an impulsive handful of pills. And when asked why they did that, they will say, I just needed to feel better. So they can end up in the hospital or in an emergency room with a presumed suicide attempt, and what they'll often report is their intent was not, in fact, to die. When their intent was to die, very frequently they will also do something very sudden, very, very rash, very quick, and within minutes they will regret it and say, uh-oh, I should call somebody. I just took an overdose of all my medications. So we see that very desperate reactive quality in their suicidal behaviors. So what about self-injury? Many people assume that self-injury is a linked behavior to suicide, and I want to start by saying a few words about what self-injury is not. From the adolescent standpoint, when they engage in self-injury, this is not intended as a cry for help. And that is a very common misconception, that somebody's cut themselves, oh, they're just trying to cry for help. Similarly, many people will say, well, she's just trying to get attention, or he's just trying to get attention with those scars. And if you talk to adolescents, many of them hide this behavior, and they're not actually wanting other people to know about it at all. Another common misconception is that this is a behavior that a lot of kids are doing nowadays, so it's kind of copycat behavior. And finally, many people see it as a kind of parasuicidal gesture. So what is it from the adolescent's point of view? For an adolescent with emerging borderline personality disorder, self-injury is a very powerful and very immediate way to regulate affect. So let's take a girl who maybe is a senior in high school, and she has applied to a number of colleges, and she shows up in school, and her best friend comes running up to her and says, I'm so excited, I got into my first choice school today. And this girl with emerging borderline personality disorder has not actually heard from any schools yet. So any adolescent in that situation is going to probably get scared, probably feel sad, may feel that they have to mask those emotions and say, oh, that's so great, I'm so happy for you. And then may soon say, oh, I'm not going to get in anywhere. And suddenly the emotions are coming fast and furious. There's fear, there's sadness, there's shame, there's anger. And if she tries to express it to her friend may say, oh, don't be silly, of course you're going to get in. Now, in borderline adolescents, or adolescents with emerging borderline personality disorder, that kind of reassurance or comfort is often experienced in the exact opposite way. It doesn't feel reassuring, it feels what we call invalidating. And thoughts like, you don't get it, you don't know, start to cascade very quickly. So let's say this adolescent girl continues to have thoughts like, I'm not going to get in anywhere, all my friends are going to go off to college, I'm going to be left at home, I'm not going to have any of my friends around me, this is a disaster. And so that emotional state is going up very quickly, and the ability to take a step back, to notice what's happening to those thoughts and feelings, think, wait a minute, maybe I need to get a little perspective here. That's not happening. So that desperation is increasing, and this is where it starts to diverge from typical adolescence, right? So let's say that girl then goes home and talks to her parents about the fact that she still hasn't heard from colleges, her best friend just got in, she's really worried. And her mother says, well, why don't we go out to dinner and go shopping, and maybe that'll take your mind off it. And her father, thinking that this is absurd, and of course she's going to get in, says, hey, don't worry about it, I saw a help wanted sign at McDonald's today. Both of these kinds of responses are moments when an adolescent with emerging borderline personality disorder may start to escalate very quickly. So she may run out of the room, she may slam the door, she may leave home and get in the car. And then that desperation is going to lead to those very dangerous behaviors. And they are frantic efforts to try to change her emotional state. Now, what happens with adolescents who engage in any of these kinds of behaviors, whether it's risky sex, whether it's self-injury, whether it's substance use or eating disorders, is that the behaviors are very self-reinforcing. And what that means is because they work in the moment to change the emotional state, they tend to recur again and again and again, and that's when they become a pattern. And when people don't understand that that is the function of these behaviors, that the adolescent's effort is to feel better, they're trying to solve the problem of their feeling, they are also very vulnerable to being misunderstood. And people start to say, oh, she's being manipulative, she's just trying to get attention, I'm going to ignore this. So that becomes a very dangerous relational pattern. Okay. And the final set of symptoms all revolve around unstable sense of self and relationships. So that flows from what I was just describing. When adolescents engage in these frantic efforts, whether they're frantic to avoid feelings of abandonment, and they're very prone to feeling that people are leaving them or don't love them anymore, or are neglecting them, when they react very strongly. People try to comfort them, and instead of saying, oh, that helps, they say, you don't get it, you're the worst. All of these kinds of reactions tend to stress relationships. So it's very common for parents to report to us that one of the symptoms that first worried them was seeing that their child's friendship relationships, their peer relationships, started to wane. Many of their good friends stopped calling, started avoiding them. So the very fear of being abandoned starts to become a bit of a self-fulfilling prophecy sometimes, because their very strong emotional reactions and some of their very risky behaviors frighten people. They're misinterpreted, and so they indeed do end up with people being pushed away, even though that was not their intent. It's also common for relationships to form very quickly and then to dissipate very quickly. And finally, I'll just say a word about identity, because I think that's one of the most confusing symptoms that we see in borderline personality disorder. When we talk about difficulty stabilizing identity, we're not talking about changing hairstyles or the kind of music kids listen to. Normative identity development involves figuring out what your beliefs are, who you are as a person, what kind of traits you have, what your values are, what's important to you. In individuals with emergent borderline personality disorder, because their moods are so changeable and because they're so desperate to keep connection with people, they will often change very quickly in terms of their affiliations, what's important to them, what they believe. And then those moments will change again, and then can develop a very strong sense of uncertainty, like, what do I feel? What do I believe? I don't know. And that lack of knowledge about the self, that lack of ability to identify who they really feel they are, is very uncomfortable. So it's really about a way that people feel about themselves rather than, whether they decide one day, I really want to have pink hair, or I want to get a tattoo. Now, in a borderline adolescent, even though the tattoo may not represent their identity, they may feel that that tattoo is who they are. And so it can take on a magnitude of importance that it probably wouldn't in another child, even though the other adolescent may really like the tattoos and may be bugging their parents to let them have one. But for the borderline adolescent, it can feel like it's their whole life. So those are a brief overview of the common symptoms that we see, and I'll just wrap up by sharing a few common final thoughts. The first is that we do now know that borderline personality disorder frequently does emerge during adolescence, and it can be reliably diagnosed, and it can be differentiated from more typical adolescent behaviors. And that emotion regulation and distress tolerance are skills that can be taught and developed during adolescence. And therefore, the course of BPD can be halted, it can go into remission, and in some cases it can be reversed. We think of it as getting normal development back on course. And finally, the most important thing to leave you with is the knowledge that there are evidence-based treatments. DBT is one, MBTA, which is mentalization-based treatment for adolescents. These can effectively reduce life-threatening behaviors and the need for hospitalization in adolescence. Thank you very much.
Great. So thank you, Dr. Mintz, for that really wonderful overview and for a lot of your insights into BPD symptoms in adolescents. We've already got some questions coming in, but I want to put a plug in to all of you. If any of you have have questions about the presentation, or if you are struggling with any issues yourself, please feel free. Even if you've got a question that really isn't related to BPD and adolescence, feel free to put it in, and I'll probably prioritize the questions that relate to adolescence, but we'll get through as many of your questions as we can. So the first question actually comes to us from the United Kingdom. Is BPD a mental illness? This person says that she lives in the UK and she has been diagnosed with BPD, but she's been told on several occasions that she doesn't have a quote-unquote real mental illness, and she wonders why that is.
Well, that's a very interesting question. I think that in the United States, we would certainly say that it is a real psychiatric disorder and it is a treatable psychiatric disorder. I think the question actually really seems related to what I talked about in the beginning of the presentation, which is there's a tendency to see BPD as normative behaviors, or in adult populations, I've heard some people say, well, isn't this just somebody who's very, very angry, and maybe that's just their personality? But I think when we look at a couple of dimensions. One is functional impairment. How much do these set of symptoms actually prevent people from living life, from going to work, from developing stable relationships, from developing and attaining goals? That's one way to look at what defines this as a mental illness or a psychiatric disorder. The other is to think about how much the person experiences subjective distress, how much they are suffering. And in virtually all the people I've worked with who meet criteria for this condition, what we hear is a degree of anguish, pain, and unbearable suffering that I think definitely constitutes the designation of a mental illness. Now, again, I don't know what the thinking in the UK is. We have had in our program a number of people actually come from the UK and have received the diagnosis there. So it does seem to be recognized, but I'm not sure who has promoted the idea that it's not a mental illness. I think we would certainly say here that it is, but a treatable one.
Yeah. If I could add at least a little bit of interesting twist, because I think sometimes when people are in need of inpatient hospitalization for a suicide attempt, for instance, sometimes insurance companies don't want borderline personality disorder to be the primary diagnosis. And they will actually refuse to pay for a hospitalization if that's the only diagnosis. And so I think even here in the United States, sometimes we have to deal with, like, what do we call it? In those cases, often we just call it major depression with a suicide attempt. And so we certainly have some of that in the United States.
Absolutely. The reluctance to diagnose it has a lot of practical implications. And I think one of the reasons that insurance companies have been reluctant to pay for treatment for borderline personality disorder is, again, historically it was seen as an untreatable condition, one that would just keep going and going and going. And now we know that this disorder can be treated on an outpatient basis, often very effectively. So as we have developed more effective treatments, there may be less hesitation to diagnose the disorder, because I think when people feel there's something that effectively can be done, and they believe that that can lead to either a reduction in symptoms or reduction certainly in life-threatening symptoms, and even remission of the disorder, there may hopefully become more willingness to diagnose and treat.
Okay, so we've got a lot of really great questions coming in. So the next question I'm going to ask is about self-injury. So this comes from a parent who, kind of understood the portion of your presentation where you explained self-injury as maybe an effective way to deal with intense emotions. And so this parent kind of asks, so what are we as parents supposed to do? Are we supposed to ignore it? Is this somehow an okay thing? And how are we supposed to respond?
That's a great question, and I'm really glad to have the opportunity to answer that. I would be very sad if anybody walked away from this talk thinking that we're condoning or supporting self-injury as an effective affect regulation strategy. What we do know is that recognizing that that's the intent on the part of the person who engages in it actually helps get individuals on board with giving it up and being willing. When we can talk to them about the fact that you really need some way to manage these emotional states, and hey, this works, they can be willing to enter a conversation about why maybe they might be willing to consider an alternative method. Because if we can accept that there's a very good reason why they're doing this, we can then get them to think about whether it would be possible to teach them some other ways. Would they like to learn to have some alternatives? And could they be willing to consider that possibility? And so the validation that they are not doing this to manipulate people, they are not doing this to cry for help or get people to respond to them in a particular way, but that they're trying to solve the problem of the emotions that they're feeling, can lead to a willingness on any patient's part to consider whether some type of treatment might be a good solution. So I think as a parent, the first thing you can do is learn more about why adolescents might engage in self-injury, and there's some good resources down, as Chris mentioned, in the left-hand side of the screen, and then that might help you be able to enter a different kind of conversation with your child and say, we know that you need help with this. Can we talk to somebody about whether there might be some other way? Because I think when we engage kids in treatment, we use what we call commitment strategies to get them on board with giving up self-injury. And the way we do that is to help them recognize that not only are there these positive immediate consequences, but usually there are some very unpleasant consequences that follow later. So in the moment that the girl who didn't get a college acceptance notice that night maybe self-injures, she feels better. But maybe the next day her boyfriend and her best friend see that she's self-injured, or she starts wearing long sleeves because she's actually very ashamed that she's self-injured. Talking to kids about the fact that the behavior may be helping, and at the same time, it's also causing some problems. Often those problems come about, kids that get asked to leave school. When they can realize that there are negative as well as positive consequences, they can be more willing to get treatment. So as a parent, I would suggest that what you do is get some more education about self-injury and see if you can engage a treatment provider who understands self-injury to maybe do a consultation with your child to talk about this.
Great. So the next question, Dr. Mintz, comes from a couple of people. I'm getting a sense that there's still a little bit of confusion, I think, obviously, around distinguishing normal, wild, crazy adolescents from BPD.
Yep.
So one person asks, is there a risk in misdiagnosing BPD and possibly labeling or stigmatizing somebody who's really just going through normal adolescence? And another person asks maybe a more focused question, very much related. So if a teenager presents with some of the criteria for BPD, but maybe has great interpersonal relationships, has steady long-term friendships, friends like to spend time with them, no issues with teachers, how do you think about diagnosing BPD in that person?
Okay, those are two great questions. Let me take the first one, and then I may need a little refresher on the second. Okay. So the first one is there a risk of possibly assigning a diagnosis of BPD when maybe that the symptoms really aren't as severe or pervasive as we would typically expect? So I think the first thing I would say is I would love the world to get to a place where that was something we had to worry about, because the reluctance to assign this diagnosis or make this diagnosis in adolescence makes it so much more likely that the diagnosis won't be made at all. So if we can reduce the stigma and people can become more comfortable making the diagnosis, I would love to worry about the problem of adolescents getting the diagnosis when maybe they shouldn't. But let's think about what happens if an adolescent gets a diagnosis of BPD. More often than not, hopefully, they will be referred for a behavioral treatment or a type of psychotherapy that has evidence, that's evidence-based and has efficacy in reducing the symptoms. So from a treatment standpoint, the worst that's going to happen is they're going to get a treatment that's going to help them regulate their affect more effectively, help them learn some distress tolerance skills, help them learn to have more effective interpersonal skills, and to practice mindfulness. So there really isn't a lot of risk in the treatment, the provision of treatment, because in fact there's a movement, at least in America now, to start teaching some of the what we call the DBT skills, the dialectical behavior therapy skills, as part of normal health classes in elementary schools. And this is actually beginning to happen. The idea here is that if we taught these skills to children as part of their normal health curriculum, we might head off emerging BPD before it even happens. Sensitive kids would learn these skills and they might never develop the emerging symptoms. From a stigma standpoint, obviously we would have to make a lot of changes in the world, and I think the reasons that we haven't been making the diagnosis in adolescents are the very reasons that you are concerned about. But I think the risk of not getting treatment is so potentially problematic. These behaviors can be life-threatening, so kids can and do die. And the other risk of not treating and not diagnosing is that the disorder will get more entrenched, it will get more pervasive, and it will become harder to treat. It's treatable in adulthood, but any behavior pattern that becomes very, very well-worn is going to be harder and take longer to unlearn. So that was the first question. Can you remind me of the second one?
So the second question is a teenager who presents with some of the criteria, but not all of them, and in particular has fairly stable long-term relationships, friendships, no problems with teachers. And how would you think about the diagnosis of BPD or emerging BPD in that situation?
You know, that's a great question. We do periodically have kids who come into our program, and I would say that is the history that we get, that they are just very likable kids who manage to have very, very positive peer relationships. What often will bring them to us, though, is that the traits that they're presenting with are the very dangerous behaviors. So some kids, it will be self-injury or a suicide attempt. Many times, kids will come to us where parents had no idea anything was wrong. They'll say, she's friends at school, she's doing well at school. We had no idea anything was wrong until the suicide attempt happened, and then it comes out that self-injury has actually been going on for quite some time. So some kids with that profile are very good at masking their emotions, but when we talk to them about their subjective state of distress, what we learn is they are in extraordinary pain. They are experiencing tremendous emotional disruption, and they have what we call apparent competence. So I'm really glad to answer this question too, which means that in some domains of their life, they're very capable and they do very, very well. And where they are not as competent is in regulating their emotions. But some of them can borrow some of those strengths that they have, and they can appear to the world as if they're managing quite well. But then it comes out that we've had a lot of kids come in and tell us they've made several suicide attempts that nobody knew about. So they might take, a handful of ibuprofen, and by just luck, they threw up and they were fine and nobody ever knew. So I think we can see kids who appear to not have that relational component. They're not as interpersonally hypersensitive, but the degree of distress they are in and the way they are managing it is quite dangerous. But we'd have to see those kinds of severe symptoms. I mean, obviously, if somebody's got great relationships and they're doing well in school and they occasionally purge, or they've had a couple of casual sexual encounters, we're not going to give them a diagnosis of BPD.
Yeah. Well, and so let me let me kind of delve into that a little bit more. So when people are really on the fence about is this BPD or not, like I wouldn't want to misdiagnose it, I wouldn't want to send my kid for treatment that they don't need. Um, uh, at the end of the day, if somebody's having problems or symptoms in one sphere, and you take them to a clinician who's trained in the treatment of BPD, and that clinician helps them with those symptoms, does it really matter whether we use the label BPD? Does it really, and would the treatment be any different if we didn't use the label of BPD?
I don't think as many, I think that's a great question. In fact, again, we have taken many kids into our program where the diagnosis, we don't require that the diagnosis be made for admission to our program. What we require is some evidence in behavioral symptoms that the adolescent is really struggling with emotion dysregulation, and that they are engaging in some patterns of desperate attempts to regulate those emotional states through behavior. And we then think they're a good candidate for the treatment that we do. So absolutely, I don't think it is always necessary to apply the diagnosis. I think what's important is to recognize the symptoms of the distress and the behavioral profile. So whether we say it already is BPD, or it might be emerging BPD, or it's BPD traits, if they have difficulty regulating their emotions, if they're beginning to engage in a pattern of risky behaviors or life-threatening behaviors, and if they're showing pervasive instability in some way, even if they're not, I think then they are good candidates for treatment, and we may not need to make that diagnosis. We would still treat them.
Great. So the next question is, somebody would like to know a little bit more about MBTA, MBT for adolescents.
Yes. I'm glad to answer that question. I was actually in the UK this summer and got an opportunity to have some training in MBTA. So MBT is another evidence-based treatment that focuses really on a capacity called mentalization. And what we see in individuals who have borderline personality disorder is that when their emotional states are highly aroused, and when they start having thoughts that lead them to experience a lot of mistrust, or they're very, very certain that they know somebody sees them in a particular way, their thinking really gets shut down, and they have a very hard time imagining that maybe what they're experiencing in the moment is one possibility, but there could be other possibilities. Maybe the person that they think hates them actually doesn't hate them. Maybe they're preoccupied with, they're not ignoring them because they hate them, they're preoccupied with something else. So MBTA really focuses on what happens when very intense emotions get aroused and thinking shuts down, and again, we see the same process that I've just described. But it focuses more on facilitating the capacity to step back and look at their own thoughts, their own feelings, and be curious. It really tries to cultivate curiosity and observation about that process. So it focuses less on teaching skills for regulating emotions and more on the thought process, the thought-emotion process that happens when individuals get very aroused by interpersonal situations. MBTA has adapted this treatment to be used in adolescents. There are some people here at McLean. There's an MBT clinic here at McLean, and there are some of us who are very interested in actually developing services to provide to adolescents. I know in our program we have a mentalization group where we use some of the techniques, but I think MBTA is still less available than DBT, and hopefully that will change.
Great. So the next question is, do you have any recommendations for parents when their child is exhibiting some of these more difficult behaviors or moods, the mood swings, anger outbursts, impulsive reactions? Any general tips for parents about what can be helpful?
Well, in our program, we teach skills to parents. So I think the skill that we have a parent group here that parents attend who have kids in our program. And We always say that if there's one skill we hope parents will walk away from our program really understanding or practicing is validation. And this is the idea that parents, understandably themselves, their own emotional states escalate pretty quickly when they're scared, when their children are reacting with a lot of anger or a lot of dangerous behaviors, or they are very worried about their kids' mood states, and they find that their attempts to comfort their children or just talk to their children aren't working very well. It makes sense that parents themselves become angry, frustrated, scared. And once that happens, parents themselves tend to get polarized with their kids. They're more prone to misunderstanding. They're more prone to saying things that the adolescent will just say, get it, or they shut down. So if you don't have a child who's in treatment, I don't know. I would love to say that there would be skills groups available for parents to learn validation, because I think we have found that when parents learn how to validate their children instead of responding with a lot of fear or anger, and they can get curious about what their child's emotional experience is, their children open up more, their children share more, and they become more collaborative around the problem. So I don't have a quick and easy suggestion for how you would learn validation, but if you have access to DBT treatment anywhere, if you have access to somebody who knows the treatment, many DBT providers are very happy who work with adolescents, are happy to provide what we call parent guidance, where we literally teach the skills to parents and help them become more effective at parenting their emotionally sensitive kids. Because one of the things we've also found is that the techniques of parenting that work with your less emotionally sensitive kids, they may work beautifully, they tend not to work as well with very emotionally sensitive kids.
Great. So the next question comes from someone who says that her daughter was diagnosed with BPD traits tendency at age 12, along with depression, anxiety, oppositional defiant disorder, body dysmorphic disorder, and OCD. She's in DBT treatment and doing actually pretty well for about a year. She's almost 15 now. However, OCD is still very prominent and persistent.
Yes.
Her symptoms primarily revolve around contamination fears. And this mother says she usually doesn't see OCD as one of the comorbid diagnoses with BPD. And any thoughts on this?
Well, let me reassure you. We see OCD as a frequent comorbid diagnosis in our program. So I can assure you, your child is not the only one. And I'm delighted to hear that your child is starting to actually get better. And on that note, usually kids who have OCD in the context of BPD or as a comorbid diagnosis need targeted treatment for the OCD. In our program, we have some clinicians who are capable of integrating the two treatments together. And at the same time, DBT alone will not remediate the primary symptoms of OCD. I will tell you what it will do, though. Many kids will come to us who've had diagnoses of OCD and body dysmorphic disorder, and they will get DBT and learn distress tolerance skills, which they're going to need when they do exposure and response prevention treatment, which is the most effective treatment for OCD. So the two treatments can go very well together when these diagnoses do co-occur. DBT is often very helpful in establishing some skills that will enable the adolescent, or the adult for that matter, to tolerate and participate effectively in the OCD treatment. But I am not at all surprised to hear that list of diagnoses. I think it illustrates beautifully what happens when we can't make the diagnosis of BPD. Now, that child may have, in fact, all of those diagnoses, and this is a perfect segue. I can pitch for my colleague, Amy Gallardi, who will be following up with the frequent diagnoses that we see that co-occur with BPD. So thank you for that question.
Great. So a couple of people have chimed in about validation, and this is a common conundrum and complex area. So one person just wants me to make a plug, and I'm happy to do it. So for those of you who don't know anything about validation and want to learn more, the NEA-BPD, the National Educational Alliance on BPD, and that link is provided in that lower left-hand corner. They offer a free family connection class that can help teach about validation. But I'm going to go to the next question on validation, which is the tough one. So this comes from a parent who says, we've learned about validation, and we are struggling with our, with the siblings of the person diagnosed with BPD, because they see it as complete permissiveness and tolerance of abusive behaviors. So help us, can you help parents delineate what's the difference between validation and colluding or enabling or agreeing with sometimes dangerous, sometimes outrageous behavior?
Great question. So we have a mantra when we teach validation, and that is this: validation is not agreement. So you can kind of tattoo that on your forehead or repeat it to yourself when you're about to try to validate your kids. Validation, the thing that helped me when I was learning about validation was to remember what it is you're validating. You are validating emotional experience. Now, you're not validating all of the thoughts, behaviors, assumptions that created that emotional experience, but you're validating that given everything that you understand, that you've heard, it makes the emotional experience make sense. So let's go back to our high school senior that can't be comforted by mom taking her out to dinner, feels devastated by dad's suggestion that there's a help wanted sign at McDonald's. By the way, those aren't really validating responses. But what would be a validating response? It's not, a parent will often say, well, what am I supposed to say? You're not going to get into college anywhere? No, of course not. What you would want to say is, it makes so much sense that when you hear that somebody's just gotten into their first choice school and you are still waiting, that you feel scared, you feel worried, you have those thoughts that you doubt, what if the worst thing happens? So you validate the feeling, but not the conclusion. And I think that's something that people often we need to validate in moments that are stressful for us too. And so it becomes very hard because you're sitting there having to manage your own fear, your own concerns, and that makes it hard to think, oh, what is this person's emotional experience? Not, would I have the same emotional experience, or let me just give her this information and then she won't have to feel scared and worried anymore, but she's telling me how worried she is. Does it make sense? Okay, so I think often that flexibility in thinking is hard for us too, that you can validate an emotion, but not a conclusion. So if somebody is screaming their head off and throwing things and you have a sibling that says, I can't believe that you're putting up with this, mom or dad, I think the important thing is to say we understand that the feeling that your sister or brother is having is so intense that she doesn't know what to do. And at the same time, we're not saying that throwing things around the room is okay. We understand that you did it because you don't know what else to do. And you must feel that angry. And at the same time, we want to find another way for you to do that so that you don't have to frighten your sister and you don't have to break the lamp and the dog doesn't have to hide in the basement, right? So again, you want to kind of bring back those consequences that you need a way to manage your anger, and we want to help you do that. And at the same time, the way you're doing that is actually stressing your relationships, and I don't think that's what you want either, right? But it is tough. It is very tough to do.
Great. What are your thoughts about psychiatric medications for adolescents in general, but also for BPD?
Well, overall, if we're just talking about BPD and not another comorbid condition, very few medications have been shown to effectively treat just BPD. Now, when another mood disorder or some other kind of condition co-occurs with BPD, which frequently is the case, medications may be helpful in treating those particular symptoms. So the problem is when people have a long list of diagnoses and they start getting multiple medications thrown at them. And for instance, I think one of the most important places to make a differentiation is between, say, bipolar disorder, which also involves a lot of changes in mood and mood states, and borderline personality disorder, because many of the times people will be put on multiple mood stabilizers, some of which may be helping and some of which aren't. So nobody is against medication being used if there are very specific targeted symptoms and we have evidence that the medication is actually helping manage those target symptoms. But to simply put somebody on a medication just because they are given a diagnosis, that doesn't really make sense.
Great. So with that, unfortunately, we are out of time. So Dr. Mintz, I really want to thank you for your wonderful presentation and your thoughtful answers. And I'm really sorry to all the participants that we weren't able to answer questions. We have a lot of wonderful, great questions that we just didn't have time to get to. But I hope that all of you will tell people about these webinars and spread the word. They're free. We really want them to be as helpful as they can be to as many people as possible. So good night, everyone.
Thank you very much.